Good morning. This is Dr. Bill White again, and I'm going to try to talk to you a little bit about a most interesting case here. There's just a lot of stuff to learn here, not just orthodontics, but how to set up these cases and things, and some ways to avoid some problems that you might confront if you don't know this or haven't experienced this problem. Now, this is a slight class 3 case, and whenever you have a class 3 case, you should really look at the blood kin to this patient, especially their parents. And I've had it jump their parents and be like their grandparents even. And I've had them bring pictures in of their family. And one time I could not get any indication of class 3 out of the mother and the father. And you ask them, is this your child? I mean, nowadays you want to make sure that you have the parents of the child, if you possibly can, without being too embarrassing or anything like that. But find out if this is actually the parents and look at them. And if they have some class 3 problem, look for it in the child. I can't remember any class 3 that I've had over the years that I couldn't find somebody in the family or somebody in their blood kinfolks, that had some form of class 3. I had this little girl, the mother and father were both just perfect class 1s, no problem at all there that you could indicate or find out, and had them bring some pictures in, and sure enough, the little girl was just like her grandfather on her father's side, and that's where it came from. So anyway, just some things you need to think about when you're doing this type of case, and it's a most interesting study just to kind of keep up with what's happening in people like this. Now, you can tell so much about the person, and I want to apologize. These pictures and things were made in 1970, early in 70, and some way or another we got some fungus on them, and you can't really get it off like that. Anyway, these were taken quite a while back, and this young lady has some problems, and they are going to get worse as she gets older. Now, we'll look at the models, and we've talked about this a lot. I mean, this is a functional problem developing here, plus a genetic problem, and I don't know the percentage of genetics against the percentage of what it is functionally, but some way or another she does not breathe properly, so she breathes through her mouth, and you look at her palate, it is way up in here, and tall and real narrow, and there's no way it could be shaped by the tongue. And then the lower arch is wider, and so you've got these cross bites on both sides of the mouth. You see, the lower teeth are out like that, instead of the upper tooth being over this way. Now, that's an indication. The tongue has to be, and I've said this so many times, has to be in the lower arch if you're breathing through the mouth. There's no way you can keep it in the top. I don't know, you might be able to prop it up like that, but this is going to develop like this if you are breathing through the mouth. And that's not the only bad thing about it. I mean, the maxilla gets narrow, and then the breathing problem gets worse, you see, as they go older. It just builds on that. So these need to be corrected real young. And I use a palatal separator in cases like this, even in the mixed dentition and everything, to do that. All right, we've got the cross bites in there. We've got a lateral, and these are twisted in here. And there's just a bunch of just regular old orthodontic things that are not big deal. But you need to know what you're up against. All right, there's some breathing problem, and you need to figure out what caused the breathing problem. If you have to send them to an ENT person or somebody, I've had people who have to have the turbinates trimmed to correct the breathing problem. The nasal septum may be deviated way to one side or blocking the airway. And you can go in with a palatal separator and just spread the thickness out of this thing. And if you balm the teeth I put brackets on them and cement them where they're just real solid, so that as the tooth goes out, the roots tend to go out with it. And that's what you want. You want the widening of this to be up in this area up here. And don't just push on the teeth. These little palatal separators or the things you put in the mouth that just push on them, the darn tooth will lean like this. And if it leans, the root goes in and the crown goes out. It may be a small amount, but it's not what you want. You want to push this out bodily in there to develop airway. Well, I could talk on this all day long, but function is a vital thing in orthodontics. Okay, now let's look from the side, and I'm sorry for this fungus in there. You just have to overlook it. This was done in 1972. The models were taken then, but this is just as up to date as anything going right now. I mean, it is just as critical in 2018, or it'll be that way in 2040 too. So anyway, we've got a narrow upper arch in here, and this is looking pretty good. It looks like it's in class 1 relationship right here. We got the molars sitting in there right, the deciduous teeth in here. It's very crowded, and back in the 70s we took out more teeth than we do now by a long shot, and we removed some teeth on this young lady, and later on I'll show that in our first treatment of her case. Class 1 molar relationship. Of course, we've got a class 3 situation developing here, so it's good class 1 right there now. Okay, now when you look at the upper arch, it's pretty narrow in here and going up, and it gets worse than that. If you look at the actual model, I mean the actual pictures of the palate, we'll cover pretty quick here. And the lower is widened out, and I'll show this with show the picture of the tongue in here. And this is 6 of 72. We didn't get started on this till later, but we took some records back in 72. All right, looking in the mouth now, you can see the same cross bites and everything. And when we look up in the roof of the mouth, I mean, you can see how steep the palate goes up in here. There's no tongue shape at all in here. So this tongue is not going up in this part of the mouth. Every time that person swallows it won't look like this if it does. And so this is going to need, and today I wouldn't even hesitate. I'd go in there with a palatal separator and separate the heck out of this thing. See, and get them functioning airway. Alright, now this is a mirror shot in the mouth. They don't have two tongues. This is looking down on the lower teeth, but we took a picture of the mirror shot to show that. But she's got a pretty large tongue. It's spread out pretty good, and it's fitting in the lower arch, and the lower arch is wider than the upper arch, and it falls into this bilateral crossbite that you see. And that is caused from mouth breathing a lot of the times. Now, here, this is a too full right here. Now, we come in and take some teeth out, and she's a little bit on the flat side, so maybe I jumped the gun. We probably would be more conservative with that than we were at this time. Okay, looking at it from this is a Panorex we've got. Now, we did one thing in the surgery and everything. We take out the lower wisdom teeth, but you leave the upper wisdom teeth to push all you can get out of it. Now, we came in and took out the bicuspids on both arches. And I'm not saying that is the absolute best thing to have done in this particular case, but we did this and it was crowded, and it's still crowded up even though we had done this. And this was probably in 73 or something like that when we did it. Alright, here we come back and take a Panorex, and this is 73, I can see that right there. And we have no first bicuspids, and it's still crowded. She didn't start functioning right in here. So you really want to get the person functioning right. That is the critical thing that we know today is more critical than getting the teeth or anything else. Get the person actually functioning correctly, if you possibly can. Now, these cerebral allergies are hard to deal with, but here we're missing the first bis and still have a kind of a crowded problem in there. Okay, we start the case, and I can't read it. I think it's 1974 when we were working on that. I see the 74 right up there. And we've banded the 6-year molars and the cuspids and the second bis, and when everything else is banded in here, but the second molars are not. In other words, this is the 12-year molar here, that's the 6-year molar, and you've got the lower wisdom teeth. Now, when you've got a class 3 developing, you get this out. And we went ahead and treated this, and we got it finished and everything, and I luckily had told the parents that her father has a class 3, a mild class 3. I said, it's possible that your daughter will grow toward this class 3 till she she'll be a little older. Most girls, 13 and a half, or 14, and they're through. They don't grow anymore. But she continued to grow some in her later teens, and she was a just like tomboyish type. She was good at sports. She was very good in mathematics, and she was helping the dentist that referred them son in his mathematics. This young man later became a dentist, and he was in my office, in our study one time, and I was showing this case, and this was his girlfriend. She was helping him with his mathematics. She, I think, went off to A&M and became an engineer in some form. But anyway, that's just part of the history of this. So this young lady had a few more male hormones, but she was very feminine and very attractive after we got through with her. Now we have to come back and redo this, and then she'll have to have some surgery. All right, let's get on through this. Of course, we're banding everybody. We banded this and finished it up, lined it up, and got the crossbite corrected, and we've got the midline and the class 3. We're pulling it back here with some class 3 elastics, and got a midline here, bringing this over and pulling this back to get the midline corrected. And we got her looking good, and then took her out and everything. And then as she got a little older, she was over at this dentist's house helping his son with the math, and he called me up and says, you know, she's getting class 3 now. She's coming back out. And so we had to come back, and I set her up for surgery for the class 3. So we'll see that in just a minute here. All right. The jaw is protruding out, and you can kind of see that developing there. And now we'll go through. We finished this and got her teeth looked good at one time, but then she continued to grow toward class 3. Now you look at, we rounded this palate out. See, we brought this out, and that helped with breathing, but not enough. Okay, and that's the lower arch, and we had everything lined up, and we closed it up and thought we were there. And I'm sorry for the fungus on there, but anyway, she got to growing further and further out, and so we had to come back, and I talked with her father and told him, you know, we had warned him ahead of time that this might happen, that she could grow out, and just genetically, because of the genetics of his class 3, she's suffering for it now. And so we did, and then we sent her into surgery, and I'll show you what they did on the surgery. Okay, the surgeon was a good friend of mine, and I had scrubbed in with him some, and he would come to the office a lot of times. I have several oral surgeons that I worked with, probably 7 or 8 of them. And they just want to know you can do the orthodontics, you see. All right, so here's the record. He took records on her after we got through it. She had grown later, and this is the way a boy sometimes does. A girl usually 13 and a half, or 14, they don't grow anymore, but she's got a few male hormones more, and so she grew out, and this is what he set up to do, the surgery. Now this is what he is planning to do. It's a mandibular setback, you see, going back. He sectioned it down. I don't think they do that exact type today. And then he did a genioplasty. He sectioned this off and moved it out and wired it in place. And you wire this. Now the maxilla he takes loose and shortens it a lot and ties it up, you see. Ties it back like that. Now, this is the result of not taking care of functioning problems, and I should have seen this girl real young and got her straightened out and breathing correctly. I didn't see her till later on down in the line, but anyway, this is what the surgery is going to be, and I'm going to show you one or two. I think just one picture of the surgery is gory enough. This surgery is no plaything. I mean, it is serious. And this is what the cephalometric analysis, what he would do, how he would do it. The oral surgeon a lot of times presents these cases in a program, and he'll work up all this stuff. And he gave this to me, and this is what he wanted me to do, is put the arch wire in here and put these little brass hooks on it, and they use those to put elastics between these little hooks, you see, and you had to go in there and fix those where they were leaning back. These are, I don't think they go to all that trouble nowadays, but back then the oral surgeon wanted you to really fix this thing up, and that's what we kind of arch wire they wanted us to put in there. Now you will see that he cuts this arch wire and does some work on the maxilla to spread and move it apart. Now here he does work up on the model. Now this is a pretty gory picture, but you see the arch wire is cut here, and then he does different sections with it. Now he wires this in. The maxilla is reduced in size. This is no plaything. I mean, what ends up by not correcting breathing and the problems that a child has early can end up with some of this orthodontic surgery if you get the person looking good again. And that's a pretty gory picture there for you. I'm sorry for it. Anyway, this is Panrex. Here's the genioplasty, and it's wired on, and I see just one wire in here. They go back in and take those wires holding the maxilla in place out. Now they remove the wisdom teeth in this process. They don't want anything else pushing on this. The tongue is bad enough, and if you keep it really retained, the tongue is big and it'll push, but if you can keep it in the class 1 relation, it pushes the whole upper and lower teeth forward till it comes to a point where the equilibrium is, it's equal all around. So anyway, here the case is after we got through the surgery. It's amazing. I see that little scar up in here, and you scrub in on that thing, you say, thank God that you grow it back. You couldn't put it back together for anything perfect. But you can put it in there good, and it grows back. And this looks nice now. And here it is, a good class 1. At this point, it's kind of a super class 1. And here's the way she looked to start with. And there's the way she looked after the surgery was finished. That's several weeks after the surgery. And that's the way the young lady looked prior to the surgery. And there's the way she looked after the surgery. There's a whale of a lot of difference. Look at the height of the facial structure here. And let me see if I can erase that. I'll back up. And the height of it here is much more. And that's where they took this bone structure off the maxilla up here to raise it up, and so you don't see the gumminess of the smile or the excess teeth as she moves. And of course, they bring her lip down too, some in here, and that's just a lot nicer looking than the other case. This changes this young lady's life, really. And there's her smile. You see the gumminess, and you see all those teeth. And here she's smiling, see. And you just see the teeth. And that finishes that up. And I've taken about 25 minutes here, 26 to finish. Thank you for watching. But there's a lot to learn about this in dealing with class 3s and bad class 2s. If you got a kid that's a bad class 2 and the parents have perfectly fine class 1s, don't be too eager to correct it, because you may correct it when they're 10, 11, or 12, and then when they get 13, 14, or 16 or more, the jaw may grow out, and then you'll have a class 3 case if you've corrected it. So don't be too eager to correct the class 2s. Wait a little bit if the parents are good. So watch where people come from, see. So I'm going to hush, and I'll move over here and stop this thing.